Can everybody see that okay? Perfect. Good evening, everybody. Thank you for joining us. I'm Mary Ambach. This evening, I will be speaking about the use of platelet-rich plasma for low back pain, the clinical indications, the rationale, and the technique. So for those of us who are using orthobiologics for spine pain, majority of our patients seek us because they failed multiple standard treatment options to provide pain relief for their chronic spine condition. They want to search for a natural and non-surgical means to heal their injuries, and they're excited about the possibility or the potential to restore and repair tissue injury. These are the potential mechanisms of how platelet-rich plasma can help low back pain. Mainly, it's due to its effect on helping tissue proliferation, modulate inflammation, and on its analgesic effects. I'm not going to go over this in detail. These are well documented in published literature, but I have it here for your reference. So we're going to briefly go over some of the RCTs that are relevant to our discussion tonight. We're not going to be discussing intradiscal injections tonight, which is probably one of the ones that has the most data to support its use using biologics. And aside from discs, epidural PRP is probably the second most that has published data on in the support of its use. This is the first RCT on comparing epidural PRP versus epidural steroid injection for chronic low back pain and radiculopathy. They enrolled 50 patients, followed them up for 6 months, and they had a caudal epidural approach using leukocyte-rich PRP versus Celestone steroids. And it was a total of about 16 ml of volume of the injectate. If you look at your graph on the right side, the red line is the PRP group and the blue line is the steroid group. And as you can see, the steroid group did better at 1 month for their pain relief. However, after 1 month, the steroid group continued to decline in its effect and the PRP group started to feel better. So the results at 6 months showed that the pain score in the short form survey, which is the functional outcome measure, was better in the PRP group at their 6-month follow-up compared to the steroid group. This is another RCT, this time comparing steroid and PRP, but this time using a transforaminal epidural approach. So they enrolled 42 patients, again, a 6-month follow-up. They used a PRP that was 3 to 5 times baseline. So it was about 2.25 billion platelets per foramen. It was a 3 ml volume injection per foramen. And if you look at your graph on the bottom left, you're seeing the same pattern wherein the steroid group did better in the first month, but then the PRP group was the one that continued to have longer lasting effects and continued on its decline for the pain score, with the mean numeric rating of 1.43 for the PRP group versus 5.43 for the steroid group. The PRP group also had a better global perceived effect compared to the steroid group. There's 4 more randomized controlled clinical trials comparing epidural PRP versus epidural steroid for lumbar radiculopathy, lumbar disc herniation causing low back pain, and these are all favorable towards PRP. And to sum up all these 4 studies, they enrolled anywhere from 30 to a little more than 100 patients, about 6 to 12 months follow-up. And the same trend has been shown wherein the steroid did better for the first few months, but then there was a consistent decline in the steroid effects after the first couple months. And the PRP offered a superior and a more sustained benefit up to the 6 to 12-month follow-up period. For facet joints, there's not much data like the epidural. There's 2 RCTs that has been published comparing facet joint PRP versus facet joint steroid injection. The first study was published by Wu, and they compared PRP versus lidocaine plus steroid injection intraarticularly to the facets. They enrolled 46 participants, follow-up for 6 months. They injected 0.5 cc a volume of PRP that was about 4 to 5 times in concentration than baseline. And their results showed that the PRP group did better and had sustained improvement over the follow-up period of 6 months. And the same pattern wherein during the first month, they both had the same results or the same improvement in their pain score and their functional outcome measures in terms of the ODI and Oswestry Disability Index and the Roland-Morris Disability Questionnaire. The second RCT is similar in that they also compared steroid versus PRP, and it was also a 6-month follow-up period. They enrolled 50 patients, and these patients had a confirmed facet joint pain with 2 diagnostic blocks that were positive for facet joint. And if you look at your graphs on the bottom left, the red line is the PRP group. The first graph on the left has the percentage of the participants on the y-axis, and then the x-axis was showing the decrease in, the months, but was showing the decrease in pain that was greater than 50%, while the graph on the right was showing the improvement in the Oswestry Disability Index, which is a functional outcome measure. And so similarly, you can see that at the first few months, the steroid group did better. It was showing the same pattern wherein the steroid group had better improvement at the first couple months. They had similar improvement at 3 months. But then after the 3-month period, you can see that the red line increased, which means there was a higher percentage of participants that had better improvement of their pain score, more than 50% improved, and of their ODI scores. For SI joint, there's one RCT comparing steroids versus a PRP. It was 40 patients that were enrolled. They injected 3 ml of Leukocyte-poor PRP formulation, and they found that at 3 months, the steroid group had a 25% reduction in the pain compared to 90% with the PRP group. And the PRP, as you can see, had a more sustained improvement in their SF short form survey 36, which is a functional outcome measure, and the modified Oswestry Disability Questionnaire at 1 month. So ever since the introduction of orthobiologics for spine pain, there has been a renewed interest in the concept of the functional spine unit. The chronic low back pain, being a complex condition, usually has multiple pain generators. And so the paradigm has shifted towards treating the whole functional spine unit, meaning including all the structures that can contribute to the symptom and to the instability of the spine, and treating all those structures for better functional outcome improvement. And so we tested this hypothesis, and we published the first study to use a personalized treatment of multi-target injection in the low back. And this was a prospective case series of 46 patients. We injected the facet joints, the intervertebral discs, epidural space, and the paravertebral muscles. And we use an established clinical criteria that includes both clinical symptoms, physical exam, and imaging studies to determine the structural targets. We followed these patients for 1 year, and we found statistically significant improvements in the patient's VAS or pain score and their functional outcome measures up to the 1-year follow-up compared to baseline. There was almost 70% reduction in the number of patients that were taking opioids. Patients were satisfied, and 82% of them would repeat the injection if need be. And using this approach, there was no reported serious adverse events that we found. And so just to summarize the RCTs that are now available, excluding the discs, there's 6 RCTs on PRP epidurally showing favorable outcome. There's 2 RCTs on using PRP for the facet joint, 1 for the SI joint, and 1 RCT using a multi-target injection. And this was a comparison of prolotherapy versus PRP. There's one non-favorable outcome by Sue, but this was a very small volume blood draw, 18 ml, and the injection was ultrasound guided. So those might have contributed to the outcome of the study. For those of you who are doing this, there's obviously some limitations of the functional spine unit approach. First of all, it can be time consuming, especially if you're doing multiple level injections. You can easily get to, at least 10 injections per session. There's no validated and established criteria for the selection of structural targets. And these are all based on basically patients' clinical experience, clinical acumen, on identifying pain generators and knowing their patients' functional outcome and ability to do certain tasks. And there's very limited published research on this approach as well, but this, I think, personally, I believe is where the future is going with regards to using orthobiologics for spine is a functional spine unit approach using multi-target injections. So for our clinical case today, we videoed a case using a multi-target injection. This is a 76-year-old retired male, moderately active, who have chronic low back pain with radiculopathy. He had L4-5, bilateral moderate neurofemoral stenosis. He's got facet arthritis. He's got 4 mm central disc herniation. So basically, the most common clinical picture that we see for our chronic spine patients. He had the clinical presentation that was consistent with radiculopathy and also clinical presentation that was consistent with facet joint pain with positive facet blocks. And in the setting of facet arthritis, spondylolisthesis, scoliosis, he also had the clinical presentation that was consistent with an SI joint pain and SI joint dysfunction with positive response to prior steroid injections into the SI joint. He didn't have any symptoms that are consistent with the discogenic kind of pain. So I went ahead and planned to do an injection of the epidural space, basically a transforaminal epidural injection at L4-5, also including the facet joints in that area, and also perform an SI joint injection on the same session. So we did a 120 ml blood draw. And for the sake of the discussion, I'm going to use the terms leukocyte poor and leukocyte rich formulation, although as we know, these are basically archaic terms now for describing the kind of formulations for PRP that we have. And Dr. Sina will describe this in more detail in the next presentation. But I did the first 60 cc of whole blood was made to produce a 6 cc of a less inflammatory kind of PRP with less leukocytes. And this was a use for my transforaminal epidural injection. It was a 3 cc injection to each foramen, so a total of 6 cc. I didn't really want to inflame his already radicular symptoms. And then for the other 60 cc whole blood, this was used to produce a 6 cc of more of a multicellular, more leukocyte favorable PRP formulation. And I used this for the joints. I did 1 cc injection to each facet joint in the L4-5 region and 2 cc into the SI joint region. And I used the remaining PPP, platelet poor plasma, about 1.5 cc to the interspinal ligament at the same level. And I used the rest of the PPP, about 2 to 3 cc to each side SI joint ligamentous complex. So the baseline platelets for this patient was 150,000 per microliter. The platelets in the PRP was 1 billion per ml, so we were able to concentrate it to about 7.5 times baseline concentration. So let me make sure that I can adjust this. Okay, so let me pause this for a minute. Okay, so this is about a 6-minute video of the injections that we did, and I'm going to try to talk over them and pause to point out certain things. So the first injection is the epidural injection transforaminally in the L4 area. And you're going to see the left L4 epidural region. Sorry, I don't know how to. There you go. Okay, so you're going to see the left L4 area here that's being injected. We started in the oblique region. Sorry, I'm having difficulty with my videos here. You saw me do a lidocaine injection in the skin and subcutaneous tissue, and I basically use a inferior subpedicular approach, superior supraneural approach. And once I was close to or touched the periosteum or the os, I switched to the AP view to see where I am in terms of the pedicle. We definitely don't want to go past that 6 o'clock line so that we don't go too far medially. As you can see, there were some osteophytes here that I was trying to maneuver to, and I was trying to get away from the osteophytes. And so this is the lateral view, and the lateral view actually is showing the needle. And I'm trying to pause this, sorry, and it doesn't let me pause. So it's showing the needle in the superior portion of the foramen, and you want this in the superior portion so that you're away from the nerve roots. And you can also see that it's posterior to vertebral body so that you're away from the vascular structures. And in the AP view, this is still a little bit more lateral. And I wanted to check if there was any vascularity in that area. And if you look at the dye contrast, some of it were spilling at first. And so I had to adjust it to go a little bit more medially to show the contrast pattern to go in the midline section. So one thing that I wanted to point out when you're using orthobiologics for the spine is that because we don't know the actual effect of the contrast on the platelets and the growth factors, you want to use as little amount of contrast as possible. And so as long as you're satisfied with the contrast, you don't have to inject as much. Like for this foramen, I was probably only injecting 0.2, 0.3 ml of volume. And then once I was satisfied that there was outlining the nerve root sleeve medial to the pedicle, I went ahead to inject the PRP, obviously non-vascular flow there. I went ahead to inject the PRP, and 3 ml was injected into that into each foramen. And I did the same thing into the to the right L4 area as well. So now let's go on to the facet joint. I injected each facet joint L4 into each side. And as you can see, you can barely make out the facet joint here because this is really arthritic. I started with the left L4-5. This was an oblique view. And after local anesthesia, I used a 22 gauge 3.5-inch needle to get into the facet joint. You can go either into the inferior capsular recess or superior capsular recess, or midline into the joint, whichever your needle and the structures will allow you to do. And then once you're positioned, you can check your view in the AP view to see if you are next to the facet joint or to midline. And this is also where you would want to check the contrast to see if you got a good capsular pattern. So I'm, again, same as the epidural, because the facets can only take, very small volume of injectate, usually 1 ml in a normal facet and 0.5 to 0.75 in a very arthritic facet. You want to inject probably about 0.1, maybe 0.2 ml of that contrast. Once you see that capsular pattern, you don't really need to inject too much. And so in the AP view, you can see that nice pattern of the facet joint capsule. And I was satisfied with that, so went ahead and took out the contrast and put the PRP injection. So with this facet, I was able to inject 0.75 cc of PRP into the intraarticularly, and then the other 0.25 I peppered around the capsule of the facet joint. Um, and did the same thing on the other side. This is now the right L45 facet joint. And again, it started with the oblique view. Once I was satisfied, I checked with the contrast, and you can see the nice capsular pattern, interarticular pattern of the dye here. And again, just 0.1, 0.2 cc of a contrast injection, and then went ahead to inject the PRP after that. Next thing that I did is to do an interspinal and supraspinal ligament injection. With this injection, you can either do this using fluoroscopy or using ultrasound, wherein you can actually see the ligaments really nicely. So if you are using fluoroscopy, you're going to start in the AP view and you want to make sure that you are midline. I just wanted to point out that the red blood tinge here in the syringe that you can see is not a vascular blood, but that was from the prior PRP from the previous injection. And so once you're satisfied that you are midline within your interspinous process, you can go lateral, and that's really where you're going to adjust the depth of the injectate. You can use a 25 gauge, but in my experience, it's really hard to inject, especially with the 3.5 inch needles, very hard to inject through the ligaments using a 25 gauge. So I typically use a 22 gauge for the ligamentous structures, and basically most of my procedures in the spine. So now you can see the needle just passing through that supraspinous ligaments between L4 and L5. This is the time that you're going to tell patients you might feel a little pressure, because for the ligamentous injections, these patients can feel this a little bit more. And so I was just going very, very slowly, passing through the interspinous ligaments, and you can go as deep as um, as deep as you can go, obviously not going to the epidural space. No contrast is needed. What I use here was a platelet poor plasma injection into the interspinous ligaments. And what I did was inject the PPP, and then on my way out, slowly injects more small aliquots until I was the supraspinous ligaments. And then when I was at the supraspinous ligaments, just kind of pepper it on top of L4 and on top of the L5 spinous process to cover these ligamentous structures as well. Okay, so the last procedure would be the SI joint. Again, the standard of care for SI joint is using fluoroscopy, although you can use ultrasound for this in leaner patients. Just know that if you're using ultrasound and you're going to the superior part of the SI joint, this is the fibrocartilaginous portion of the SI joint. So you kind of have to dig in a little deeper just to get into the joint. The traditional approach is to go through the synovial portion of the joint, which is the inferior part of the SI joint. And so the fluoroscopy is positioned cephalad and either ipsilateral or contralateral view to show the different uh, outline of the SI joint. So the medial lucency here is the posterior joint. So that's your target. The lateral outline here is the anterior portion of the SI joint. So once I was satisfied with the needle tip in the medial lucency, we then go into the lateral view to check the depth and to make sure that the needle tip is in the area where the SI joint territory is. This is probably a little bit more superficial and too early for me to check the dye. And you'll see the initial pattern is more of a soft tissue pattern here. right about there. And so I adjusted the needle a little bit deeper to get to the SI joint territory. And once I saw a little bit of that capsular pattern into the inferior SI joint, I stopped. Again, same principle where you don't really want to inject too much into these joints. You want to fill the joints with the biologic rather than the contrast. And so with the AP view, it showed me the inferior portion of the SI joint there. And once I saw that, I was satisfied and was ready to inject. It's very hard to get an SI joint arthrogram, as a lot of you can probably relate. And you don't really want to get a full arthrogram picture here because your goal is really to inject the biologic. And so I was able to inject 2 cc of the PRP intraarticularly. And what you can see here is on my way out, I was peppering some of that PRP into the dorsal inferior SI joint ligamentous complex and use PPP for the inferior ligaments. And then I did the same thing into the superior dorsal SI ligaments and into the iliolumbar ligaments. You can also use a dye here to confirm, especially in the iliolumbar ligaments, that you are ligamentous. Or you can use an ultrasound, which can actually show you the ligaments better than fluoroscopy. And you can also include the sacrotuberous and sacrospinous ligaments in your whole SI ligamentous complex here. So this was PPP being injected, making sure that you are in the cortical area and not into the peritoneum. Okay, so take-home points. Biologic treatments of the spine will need a personalized whole functional spine unit approach. There is now increasing evidence of good quality data. I think the last systematic review had level 2 evidence for PRP for low back pain, but there is now increasing good quality data on its safety and efficacy for PRP use for the discs, the epidural space, facet joint, and SI joint. And we need more high quality studies along with real world evidence to move the orthobiologics field forward, especially for spine pain. Thank you very much. These are my contact information. Feel free to contact me if you have any more questions.